and Deputy Chief Medical Officer at Smilow Cancer Hospital. And in her roles, both as Chief Quality Officer, as a leader in the breast program, and really throughout her work in health services research, Kerin really has been instrumental in our cancer center to innovating with regard to understanding the field and moving it into interventions in the clinic to improve quality of care, to improve outcomes, to improve our cost effectiveness and delivery of care, and frankly, moreover, learning from that and returning it back to the research arena. And she's done that on multiple forums, both here, regionally, and nationally. And so pleased now to hear about Kerin's continuing work on My Pathway and other things. So Kerin, thank you.
Thank you. Can you hear me?
Yes.
Okay, great. So I'm really excited to present this body of work. This work really grew out of an idea I had probably even before I came to Yale 6 years ago. And it was really in a quite deep collaboration with researchers at Genentech that we were able to really put some teeth behind the idea and begin to really develop this concept. Again, it's a collaboration between Genentech and then really our COPPER group at Yale, our cancer outcomes group. And I just have such wonderful collaborators on this who I will go through and thank at the end. These are my disclosures. So at this point in time, about 60% of patients treated systemically for cancer are treated with the use of clinical decision support or clinical pathways. So if you think about that, making sure that pathways are both effective, evidence-based, and represent the patient's voice really has the potential to have tremendous impact on the care received by patients across the country and even internationally. I wish I could see your faces, but do people know who this is? This is Gene Wilder, who's really one of the funniest movies of all time, Young Frankenstein, Frankenstein, but he called himself Young Frankenstein in this movie. And this really gets at the concept that traditional medicine was practiced on the idea that the doctor knows best, and that whatever the doctor thought should go was the patients the treatment got, the treatment that the patient should get. And in cancer in particular, where for decades our outcomes were terrible, there was this concept of the oncology chef who was going to give you a little pinch of this and a little pinch of that, and it would be just perfect to fight the tumor. But in fact, we know that treatments were highly toxic, and for many years, outcomes were terrible. Luckily, we're in a new age of cancer treatment. But it's this idea of evidence-based medicine, right? The idea that we should be treating people based on firm scientific evidence, well-conducted clinical trials and meta-analysis, and with good scientific method behind it that should really be dictating how we treat our patients. And this has really taken root in the last couple decades and really is the standard of care for cancer care today. I also want to talk a little bit about the concepts of quality improvement science. So Edward Deming was really the father of quality improvement science, and he focused heavily on the idea that when systems work right, errors are minimized, and that most of things that go wrong come out of failed systems, not failed individuals. He has lots of wonderful quotes if you ever look him up. He said, in God we trust, everyone else should bring data. And that without data, you're just another person with an opinion. And the Plan, Do, Study, Act cycle is sort of pathognomonic for quality improvement science, that everything we do, we should measure and revisit and continually work to improve. And we know from lots of work in the aerospace and the auto industry, where Toyota really worked with the Lean program, that if you eliminate unnecessary variation, and this applies to healthcare as well, you can reduce errors, improve outcomes, and we've seen actually through lots of clinical pathways reduce cost. And so it's really these two concepts of evidence-based medicine and quality improvement science that join together in the concept of clinical pathways in cancer care. So how are pathways different than guidelines? So for anyone who has used NCCN guidelines, they're often very, very broad, where there could be, as many as 10 or 12 choices for a given clinical scenario. And the ideas with pathways is that you are buying in, or your institution is coming up with a set of principles that guide us to a narrower selection of choices and allow us to do that process improvement and look at keeping things particularly safer by doing them consistently in the same way. And for academic centers, one of the real big selling points for clinical pathways is that for a specific disease or scenario, clinical stage, you can prioritize clinical trials as the first choices on those pathways. And those clinical trials can be the trials available at your particular cancer center. So I'm going to talk a little bit about what I call the 5 Ps of pathways, because there are many stakeholders that play into this. So there are the payers, who on one hand really need to reduce the cost of treatment. And on the other, especially when you think about employer-sponsored payers, where the payer is actually the employer, right, who's got representing a population of employees who they self-insure, they really want to make sure that their employees are getting the most evidence-based best treatment out there. There are the providers who have to use these pathways and who have to agree with the logic that's behind each clinical decision point. There are the pharma companies who work hard to get their drugs approved and want to make sure that there is a place for their drugs on the pathways. And most importantly, there are the patients who have to live through the treatments that the pathways recommend. And in traditional pathway generation, so that, via oncology, which is the pathway program that we subscribe to here at Yale, there is this hierarchy of priorities. And the main concept is that the most important thing is efficacy. And if there are more than one treatments that share equal efficacy, then we look at toxicity. And when they say when toxicity is equal, only then do we even take cost into account. And in via oncology, for example, costs ends up only figuring into the pathway choice 5 or 10% of the time. But I'm going to think a little bit about this notion of toxicity, right? And did we potentially leave out elements in this hierarchy that might be critical to a patient? So one of the criticisms of pathways is that this is cookbook medicine, that we've removed the individual clinical judgment from each decision point that a doctor may bring to the and expertise that they may bring. And in this age of personalized medicine, some worry that clinical pathways are actually depersonalized medicine. So when we go back to this hierarchy, I'm going to talk a little bit about toxicity. How do we say that 2 toxicities are equal? A grade 2 neuropathy may mean something very different to the violinist, and a grade 2 anemia may mean something very different to the high altitude marathon runner. And so we need to ask, what do these pathways actually leave out? What did we forget when we developed this hierarchy? And what we really forgot is the patient's perspective. And the rest of this talk focuses on how we begin to incorporate the patient's perspective into clinical pathways. So what do patients care about? Patients want to know, will they feel sick? Will they be able to work? Will they be able to pay their rent while they're on treatment? And will this treatment and all the toxicity they may endure actually help to cure their cancer? And one thing that we've done a terrible job about in medicine is acknowledging the burden of treatment and actually educating patients about what to expect relative to this. And I'm going to give you an example. So I'm going to show you 3 different chemotherapy regimens. In some trials, these are considered equal efficacy-wise when they've been compared. In some, there may be small differences in efficacy. But for an individual patient, those small differences are often only in the range of 1 or 2%. The first regimen that we use very frequently in breast cancer is given once every 3 weeks, 4 times. It's 3 months of a patient's life on treatment. The next regimen, called dose-dense therapy, is given once every 2 weeks, a total of 8 times. 1 regimen for the first 4 and 1 regimen for the second 4. It's double the number of treatments, and it's an extra month on therapy. The final regimen is what we call dose-dense AC followed by weekly Taxol. And this regimen is given once every 2 weeks, 4 times, and then weekly 12 times. So if you think about a patient, this means they're making 12 more visits to the infusion center. They're paying for parking, they're getting babysitters, and it's an extra 2 months on therapy, which could mean 2 additional months outside of work. So which regimen do you think, sorry, my phone is ringing. Which regimen do you think is preferred on all clinical pathways and recent clinical trials? It's the most intensive, highest treatment burden regimen that I've mentioned so far. And the reason this regimen is embraced on pathways is that when you give the second part of it each week, you don't have to give a growth factor, which is expensive, a growth factor called Neulasta. So when we talk about cost and we talk about savings, this regimen may be less expensive to the payer, but when we talk about cost, who are we talking about cost to? Is it cost to the payer, or is it cost to the patient who now may be missing 2 additional months of work? And whether or not, as a physician, I prefer one of these regimens to another, the question is, are we really doing a good job giving our patients the understand potential differences and make treatments that are aligned with their preferences? So the cancer support community actually did a study in this age of sort of quality and value in cancer care, where they said to patients, well, how do you define value? And they didn't define it economically. Value to a patient was care that was aligned with their personal values. They wanted to be treated with respect, communicated with in an understandable way. They wanted choices, and they wanted, of course, the best outcome. So the National Quality Forum has a group called the National Quality Partners who got on board with this concept and issued a call to action that all practices and organizations that are treating patients figure out ways to pay for and utilize shared decision-making in actual care delivery. So how do we define shared decision-making? So shared decision-making, according to NQF, is that working in partnership, clinicians and patients make informed decisions that are consistent with patients' values, goals, and preferences. And ASCO got on board with this too. I want to say that we actually started working on this project before NQF or ASCO initiated these calls to action. But ASCO has 15 criteria for high quality pathways, and one of the factors is whether or not the pathways account for differences in patient characteristics and or preferences. So if you think about the pathway program we use here, VIA Oncology does account for some medical differences between patients, like whether or not they're at high risk for cardiac disease, but really doesn't do anything to take into account patients' preferences. And the president of ASCO, former president of ASCO, Dan Hayes, had written that well-designed and effectively implemented clinical pathways can support the delivery of evidence-based cancer care while enhancing communication and education between a patient and his or her physician on the complex details of a treatment plan. So really articulating the motivation behind this project from the beginning. And the last time I looked did a comprehensive review, there was no pathway product on the market that incorporates the patient's perspective, no complete pathway product. There are different things that come primarily out of research institutions for specific disease scenarios. So our objective here in my pathway is to facilitate shared decision-making and turn the tables on clinical pathway development by engaging patients in both the design of pathways and the actual involving them in the use of pathways that will ultimately lead to their own treatment. So it's a 3-phase project. We've now completed the first phase, which was qualitative research on both patient and caregiver perspective. It's been submitted as of yesterday. The minor revisions have been submitted to the Journal of the Patient, so we're very optimistic it will be accepted. And for the point of today's talk, I'm going to focus on the patient perspectives, not the caregiver's perspectives. And then phase 2, which we're really excited and should be embarking on soon, is the design, build, and user testing of a shared decision-making pathway prototype. And finally, in phase 3, we will test this in a prospective cohort trial to understand whether patients who use the program will be more satisfied with their decisions than those who don't. The qualitative work was led by my amazing colleague, Dina Schulman-Green, who has been at the Yale Nursing School and is moving to NYU soon, but will stay very, very involved in this project and in the user testing component as we go forward. And it was actually an oral presentation at the International Conference on Shared Decision-Making that our team member Shi Wang gave in Quebec City in 2019. So the methods, this was a qualitative interview study. We used interpretive description as an approach intended to inform change in clinical practice. Enrollees were women aged 18 years and over, treated for stage 1 to 3 breast cancer at Smilow Cancer Hospital. We did 30 to 45-minute individual interviews that were focused on the factors affecting patients' decision-making. And we asked a lot about their preferences for learning about and weighing treatment burdens and outcomes. And we also asked about their attitude towards using an electronic decision-making platform. Interviews were recorded, transcribed, coded, and analyzed for themes. So there were 22 patients and 20 caregivers in our sample. The mean age was 56. They had somewhat equal distribution between stage 1 and 3 breast cancer. We did not include patients with stage 4 breast cancer, though we believe this is an absolutely critical population to provide help with decision-making too. But for the scope of building a prototype, we had to keep it relatively narrow or it would have just become too big. And the mean months on average since diagnosis was 42. So these were patients who had perspective and some distance from the treatments that they had undergone. Patients really identified issues related to 6 themes. So the themes were focused around the provider, the healthcare system, treatments they received, physical effects of treatment, implications of prognosis on treatment choices, psychosocial factors, and family factors. So in terms of the theme on the relationship to providers in the health system, patients talked a lot about their trust in providers, wanting a consistency of care, and the importance of communication. So one patient said, if I feel trust, if I feel like my caregiver, referring to their professional caregiver, really knows what they're doing and is listening to me and is looking at me as an individual, I'm going to trust them and I'm going to weigh their opinions pretty heavily in my decision making. This quote that I'm going to read next is, I really just think so beautiful, and it just shows us how much we can learn from our patients. But the themes related to treatment focused a lot on the expected response to treatment and side effects. Patients wanted to know what to expect and what was coming, the weighing of pros and cons, and the incorporation of other patients' stories that they heard in the decision-making process. And participants also expressed the importance of balancing their own treatment preferences with provider-recommended standards of care. And this patient says, I want the best possible medical advice and opinion informing decisions that I make. I don't want to make them on my own, and I don't want a doctor to make them for me. I want to be, if not in the driver's seat, then strapped into the passenger seat, making decisions collaboratively. I just, this is so beautiful, and I think it really talks about that importance of shared decision-making. Patients had lots of concerns about physical factors related to symptom burden, physical appearance, and decisions that were partly made, age played a large factor. So one patient said, I had zero idea of the reality of the outcomes, and I did not aggressively pursue insights into what the other side of treatment would be. I wanted to pursue a course that was as aggressive as possible. I would have liked to have better understood the implications of aggressive treatment. And I think one of the things that we can start to feel in this quote is that this is a patient who might have some decision regret. wishing that she had actually understood what she was deciding on more than she did. In terms of prognosis, the theme captured factors that were related to disease course, such as risk of recurrence, disease severity, and survival. If the chance of recurrence was minimal, the patient says, I probably wouldn't have done chemo, but being that my oncotype score was so high, when I was shown all the statistics, it was a no-brainer for me. I had to do it. Psychosocial factors and the interrelation of emotional and social issues were also critically important, including the ability to perform unusual roles, the potential of decision regret, and the impact on quality of life. This patient said, I was divorced and I had a 14-year-old, and I was concerned that if I needed to be there for him and that if I made these choices to have these major surgeries, was I going to be able to take care of my son when I was finished? And in terms of family, patients really wanted to understand the impact of their treatment decisions on both their family caregivers and their children. One patient said, I don't think I would say no without trying it first. I have a lot of reasons. I have my mother, I have my grandchildren. One has a steady boyfriend and I want to see her get married. We heard a lot about the importance of family milestones. And then the other thing that we really began to understand as we did the qualitative analysis is that patients really struggled with tensions. There were competing forces in these different themes. And so some of the tensions that arose in decision-making are the following. So patients wanted to have enough information to set expectations, but not so much that it became paralyzing and that they couldn't make a decision. Sorry, patients had to balance the desire for the highest likelihood of cure with the negative physical, emotional, social, and financial consequences of treatment. And that is a major thing that patients struggle with. And finally, patients wanted to make evidence-based decisions, right, based on clinical trials and population level data, but they wanted to feel that their treatment plan was personalized. And again, these are somewhat competing priorities. So these are findings that will really inform the decision of the design of my pathway. So one issue is that unresolved tensions lead to decision regret and can have long-lasting impact on patients' emotional well-being. A second thing that we learned is that decision-making does not occur in one visit to a doctor's office at one moment in time, but actually occurs over time, and patients continually revisit their potential decisions over time in discussions with caregivers, discussions with friends and family, some of whom have had cancer treatment themselves, and then in whatever form of individual research they do. This can include giving the binders that we give, but I think more often is, reading about different treatments online. We found that patients were really willing to tolerate side effects and impact on quality of life, but they wanted to be better informed about what to expect before they made a decision. There was a lot of frustration when patients, after going through a treatment, ended up living through long-term toxicities that they had not anticipated before starting. So what does this mean for our design? Well, the design of our shared decision-making tool is going to have to facilitate exploration of the 6 themes that we've described above. It's going to have to allow patients to return to the program in their own time and space to accommodate this idea that decision-making is a dynamic process that occurs over time. And the pathway is going to have to help elicit and clarify patients' values and goals to help them navigate through these competing tensions and towards a decision that best aligns with their goals. So we're using these insights from phase 1 to build the prototype of a shared decision-making tool. So essentially, there's going to be a provider-facing component, which will be an evidence-based clinical pathway, a little like Via Oncology that we use, but it won't be as narrow. The idea is that we want to give patients the exposure to multiple evidence-based options so that in the patient-facing module, they can really begin to explore efficacy, toxicity, and treatment burden, and other factors such as, cost of treatment, frequency of visits, to allow them to ultimately choose from these evidence-based options. And as a result, the combination of this provider-facing and patient-facing modules will come together in a shared decision. So for the prototype, we had to pick 3 decisions, and we wanted to pick the different modalities of treatment for early stage breast cancer, including surgery, medical oncology, and radiation. And we wanted to pick decisions for which there was gray area, where there were choices. Otherwise, we wouldn't really be testing a decision-making tool. So the decisions that we've landed on, for the surgical decision, it is the role of a contralateral prophylactic mastectomy. So this is a very common practice nationally, and yet having a prophylactic mastectomy and removal of a healthy breast is not associated with any survival benefit. There may be emotional, psychological, and cosmetic reasons for doing this, but I think the pathway will really help patients clarify their decisions in this setting. The second decision is like the one I shared with you earlier about which chemotherapy regimen to receive. And when going through it, patients will actually be giving prognostic data related to their specific disease presentation. And finally, we will be using a body of work that Shi Wang has already done, helping to model the benefits of post-mastectomy radiation in older women. Again, another gray area that is not associated with a survival benefit. And so the idea is that after going through this process, patients will ultimately be able to navigate through their treatment journey, and that every decision they would have to make will be made with this increased access to educational material. Ultimately, this product would include every decision point for every presentation of cancer, but obviously that is a huge build. So the idea is that the first thing that would happen on this journey is that the physician would navigate the pathway and enter clinical staging data and select the physician's preference from a list of evidence-based options. And the reason we need to do that is there are many patients who really truly want their doctor to decide for them, and we need this program to accommodate all different sorts of decision makers, those who want their doctor to decide and those who really want to decide themselves. And then the patient can log in and explore efficacy, toxicity, and treatment burden data for each evidence-based option. They'll also take a preferences assessment or a values assessment, which will then help tell them where the different treatments lie on their own preferences scale. Ultimately, the patient will select the treatment that they're interested in and follow up with the physician to discuss it. And finally, the patient will be able to print out a personalized treatment roadmap, which they can bring throughout their journey. Finally, in phase 3, we will test this tool in clinical practice. So this is going to be a prospective cohort trial to minimize the risk of actually contaminating the providers, because once they engage in using this tool, it could ultimately change their practice. So the primary outcome will be the score on a validated decision conflict scale, and we hope to see improvement. And the secondary outcomes will be secondary outcomes are the score on actually the validated decision regret scale, where we also hope to see improvement. Finally, the entire team here really believes that a shared decision is the best decision, and I hope that we can facilitate that. Thank you. Just quick thanks to this incredible team: Dina Schulman-Green, Shi Wang, Sarah Mugalian, Carrie Gross, Sophia Munn, Maureen Canavan, Renee Capasso, Emily Cherwin, and Helen Sayward, and the Genentech team: Sharmi Patel, Esprit Ma, Preeti Bajaj, Catherine Equal, Isabel Markle, and Ricky Varghese. Thank you.
Kerin, thank you. That was terrific. It's an incredibly complex arena to help providers and patients sort this out, and it's really exciting the way you're taking this on. Let me ask, how can you maybe describe the interface in terms of, and most importantly, like for the patients, because there's a there's a lot of important stuff that you're bringing together to help them. What would, can you give us a sense of the perspective, the point of view from the patient, how this would look?
Yeah, so we will actually be partnering with a group that has a lot of technical skill and ability and has built a lot of patient-facing interfaces before to actually do the build. But the patient would be able to log in. It'll be web-based. They'd be able to log in from their computers. We're debating whether or not the phone would work. It may not be able to show enough detail. And when they log in, they'll be able to see, they'll actually be able to select how they like to view data, right? Do they like numbers, statistics? Do they like pictographs? And then we'll be able to actually represent data for them, both on prognosis and toxicity in the format that they are most comfortable looking at and viewing with. And then we'll have lots of educational material about all the different options that they can cycle through. They'll have visual representations, a little like the ones I showed for the different chemotherapy regimens. They'll even be able to see pictures of, breast reconstruction, and so it should be a sort of a fairly deep layered investigation. And one of the things that McCann Health, who we're talking to about doing this work, has talked about is that you can actually use chatbots to encourage patients to go sort of in different trails. If it seems like a patient is interested in one thing or maybe missing a certain line of investigation, you can actually prompt them to go further and learn more. So, McCann Health has a whole lot of expertise in this. And so, sort of excited to, build on the partnership with that.
What do you think your timeline is to get into phase 3?
So the budget, I think it's probably a 3-year timeline. I have to look at it again. The timeline has to, there's build phases and then user testing phases. So, and for each module, there's a revision with a 2-month testing phase where we'll actually be trying this with patients and with providers, right? Because the providers have to like their module as well. So I think the whole timeline will be over 3 years until completion of the 3rd phase.
Well, that's fantastic. I know we're out of time. We're a few minutes past the hour. I want to thank both Kerin and Melinda for 2 outstanding talks and really superb work in really the population science world as it's translating into improved patient care and understanding how we can deliver better care and understand the biology of these diseases. Thank you all for attending and have a good day.
Thank you.